Nipah virus (NIV) is a zoonotic virus. It is transmitted from animals to humans, and can also be transmitted through contaminated food or directly between people. In infected people, it causes a range of illnesses from asymptomatic, subclinical infection to acute respiratory illness and fatal encephalitis. The virus can also cause severe disease in animals such as pigs, resulting in significant economic losses for farmers. Although Nipah virus has caused only a few known outbreaks in Asia, it infects a wide range of animals and causes severe disease and death in people, making it a public health concern. Past outbreaks. Nipah virus was first recognized in 1999 during an outbreak among pig farmers in Malaysia. No new outbreaks have been reported in Malaysia since 1999. It was also recognized in Bangladesh in 2001, and nearly annual outbreaks have occurred in that country since. The disease has also been identified periodically in eastern India. Other regions may be at risk for infection, as evidence of the virus has been found in the known natural reservoir Pteropodidae bat species and several other bat species in a number of countries, including Cambodia, Ghana, Indonesia, Madagascar, the Philippines, and Thailand. Transmission. During the first recognized outbreak in Malaysia, which also affected Singapore, most human infections resulted from direct contact with sick pigs or their contaminated tissues. Transmission is thought to have occurred via unprotected exposure to secretions from the pigs, or unprotected contact with the tissue of a sick animal. In subsequent outbreaks in Bangladesh and India, consumption of fruits or fruit products, such as raw date palm juice, contaminated with urine or saliva from infected fruit bats was the most likely source of infection. There are currently no studies on viral persistence in bodily fluids or the environment, including fruits. Human-to-human transmission of Nipah virus has also been reported among family and caregivers of infected patients. During the later outbreaks in Bangladesh and India, Nipah virus spread directly from human to human through close contact with people's secretions and excretions. In Siliguri, India in 2001, transmission of the virus was also reported within a health care setting, where 75% of cases occurred among hospital staff or visitors. From 2001 to 2008, around half of reported cases in Bangladesh were due to human-to-human transmission through providing care to infected patients. C. Morbidity and mortality due to Nipah or Nipah-like virus encephalitis in WHO Southeast Asia region, 2001 to 2018. Signs and symptoms. Human infections range from asymptomatic infection to acute respiratory infection, mild, severe, and fatal encephalitis. Infected people initially develop symptoms including fever, headaches, myalgia, muscle pain, vomiting and sore throat. This can be followed by dizziness, drowsiness, altered consciousness, and neurological signs that indicate acute encephalitis. Some people can also experience atypical pneumonia and severe respiratory problems, including acute respiratory distress. Encephalitis and seizures occur in severe cases, progressing to coma within 24 to 48 hours. The incubation period, interval from infection to the onset of symptoms, is believed to range from 4 to 14 days. However, an incubation period as long as 45 days has been reported. Most people who survive acute encephalitis make a full recovery, but long-term neurologic conditions have been reported in survivors. Approximately 20% of patients are left with residual neurological consequences such as seizure disorder and personality changes. A small number of people who recover subsequently relapse or develop delayed onset encephalitis. The case fatality rate is estimated at 40% to 75%. This rate can vary by outbreak depending on local capabilities for epidemiological surveillance and clinical management. Diagnosis. Initial signs and symptoms of Nipah virus infection are nonspecific, and the diagnosis is often not suspected at the time of presentation. This can hinder accurate diagnosis and creates challenges in outbreak detection, effective and timely infection control measures, and outbreak response activities. In addition, the quality, quantity, type, timing of clinical sample collection and the time needed to transfer samples to the laboratory can affect the accuracy of laboratory results. Nipah virus infection can be diagnosed with clinical history during the acute and convalescent phase of the disease. The main tests used are real-time polymerase chain reaction (RT-PCR) from bodily fluids and antibody detection via enzyme-linked immunosorbent assay (ELISA). Other tests used include polymerase chain reaction (PCR) assay and virus isolation by cell culture. Treatment: there are currently no drugs or vaccines specific for Nipah virus infection, although WHO has identified Nipah as a priority disease for the WHO Research and Development Blueprint. Intensive supportive care is recommended to treat severe respiratory and neurologic complications. Natural host: fruit bats of the family Pteropodidae, particularly species belonging to the Pteropus genus, are the natural hosts for Nipah virus. There is no apparent disease in fruit bats. It is assumed that the geographic distribution of henipaviruses overlaps with that of Pteropus category. This hypothesis was reinforced with the evidence of henipavirus infection in Pteropus bats from Australia, Bangladesh, Cambodia, China, India, Indonesia, Madagascar, Malaysia, Papua New Guinea, Thailand and Timor-Leste. African fruit bats of the genus Eidolon, family Pteropodidae, were found positive for antibodies against Nipah and Hendra viruses, indicating that these viruses might be present within the geographic distribution of Pteropodidae bats in Africa.